Susan, Dr. Yan, Dr. Smith, thank you for giving me the opportunity to talk about this topic. I think this topic is very important. If you are a medical oncologist, this is extremely important. If you are a nurse practitioner, this is very important. If you are a surgical oncologist or a radiation oncologist, I think it's very helpful because that's going to help you take care of your patients. I have no disclosures. So I'm going to start my presentation by giving 3 case scenarios that hopefully will give a good introduction to my talk. So this is a 62-year-old male patient with stage 4 rectal adenocarcinoma with metastases to the bone and lung. Patient was treated with FOLFIRI and Avastin. FOLFIRI has fluorouracil. Treatment was well tolerated with nice partial response. This is a very common scenario that we have in the clinic. And this patient was doing well. The second patient is a 48-year-old female patient. She had stage 4 rectal adenocarcinoma with liver metastases. Again, she was treated with FOLFIRI and Avastin. FOLFIRI has fluorouracil and irinotecan. After cycle number 2, the patient was admitted because of grade 3 diarrhea. She had dehydration and hypokalemia. Stool workup was negative. Her symptoms, fortunately, improved shortly after she finished cycle number 2. We did look for germline DNA mutations, and she was genotyped for 5 variants. None of them came back positive. Because she was treated with irinotecan also, she was tested for UGT1A1, and that was unremarkable. We could not identify why she had so much toxicity. We cut down the dose by 50%, and she did well. So this is an example of a patient that had toxicity, but we couldn't identify what's going on with her. The third patient is a 43-year-old male patient who had stage 4 colon adenocarcinoma with liver mets, treated again with FOLFIRI and Avastin. After cycle number 2, he had the similar outcome. He was admitted because of dehydration and hypokalemia. Stool workup was negative. Symptoms improved, resolved after a few days. When we looked for germline DNA mutations, he was found to have a heterozygous mutation in the DPYD9B variant. So in that patient, we identified a mutation that led him to develop this toxicity. The dose of the 5-FU was reduced by 50% and then titrated, and he did well. So those are just 3 examples of 3 different patients. One of them had absolutely no toxicity. The other 2 had toxicities. One of them we were able to identify what's going on. The other one we just could not. So this is going to take us to our topic today. Fluoropyrimidines is a class of chemotherapy. If you practice here in America, you would be familiar with the IV fluorouracil, which is the active form of the drug. And also you would be familiar with the oral form, which is capecitabine or Xeloda, which ultimately become converted to IV fluorouracil in a 2-step enzymatic conversion. If you practice in Japan or Europe, you probably would have prescribed Tegafor, which is a prodrug that ultimately become IV fluorouracil. So whether you give any of those 3 drugs, then you are dealing with IV fluorouracil. Now, fluoropyrimidines are the cornerstone for treatment for GI tumors. And anyone who does treat GI tumors use 5-FU all the time. Now, if you treat breast cancer, then probably you have used Xeloda. If you treat head and neck cancer, then you have probably used 5-FU. A patient of Dr. Butler the other day, he was getting DCF, which has 5-FU. Dr. Norder, I'm assuming that she used Xeloda when she treated patients with breast cancer, she and Dr. Cameron. So where did this enzyme come from? What's the function of this enzyme? If you give a patient 100 milligram of 5-FU, 80 to 85% of the drug ultimately become completely metabolized and not used or not exert any toxicity or cytotoxicity to the cells. That's a big fraction of the chemotherapy that we give. In addition to this, also another big fraction just get excreted. So you only end up actually using a small fraction of the drug that will exert its toxicity on the cells. And that's pretty important. So if you lack the enzyme, the DPD enzyme, then you will end up having a very big fraction that ultimately is going to affect the cells and exert the toxicity. So how do we assess the DPD, dihydropyrimidine dehydrogenase enzyme activity? There are 3 methods, but we typically now use only one of them. The first one is the radioenzymatic assay. This is supposedly the gold standard because it detects the enzyme activity. It has advantages and disadvantages. It detects the enzyme activity. It's quantitative. It gives you a number. But it's time-consuming, complicated, not readily available. And the enzyme itself has a circadian pattern. So that makes it difficult for you to use this method. The breath test is another method that we typically don't use. But it detects the DPD activity. It's quick, non-invasive, cost-effective. It provides you with a quantitative measurement. But also it's not readily available. It deals with the circadian pattern of the enzyme. And interpretation can be somehow difficult. So we usually do the genotyping for the DPYD gene. The advantages of this, it's reproducible. If you have a mutation, you should be able to identify this mutation every time. And it doesn't give you a quantitative measurement, but it can give you whether the patient is a heterozygous or homozygous. The disadvantages, like I said, it's qualitative. You need to test for multiple variants. We will talk about this. And also, it gives you the gene data, but it doesn't really give you the final product, the protein data. So what's the incidence? I'm going to show you, in the next slide, I'm going to go over the incidence of this enzyme. But this is a slide to show you how one of the studies looked at the incidence of DPD deficiency. They looked at patients with breast cancer and healthy females. And they took their blood, measured the DPD activity. And this is on the x-axis, you can find the level of the enzyme. They decided that 0.1 is the measurement below which you are deficient. And in this study, they found that 5.8% of the patients with breast cancer have DPD deficiency. Apparently, none of the healthy adults in that study was DPD deficient. But if you look here, I summarized the trials or the studies that were done to look at the DPD deficiency incidence. So the first 2 basically give us the idea that this enzyme seems to be deficient in 3 to 5% or 3 to 6% of the population, Caucasian population. That's using the peripheral blood mononuclear cells, radioenzyme assay activity. The first study, they looked in patients with breast cancer, the one that I showed you before. The other one looked mostly at patients with head and neck cancer. So generally speaking, the incidence of this enzyme is thought to be between 3 to 5 or to 6%. Other studies have shown that there is a variation between African American and white by Lori Kay. If you see here, African American seems to have higher incidence of the enzyme deficiency by 3 times. In other studies, they identified at least 1 Indian patient who had DPD deficiency. In Asians from Japan, the incidence seems to be between 0 to 0.7%. So if you look at those trials, you can understand and appreciate that there seems to be an ethnic and geographic variation in the incidence of this enzyme deficiency. The last 2 looked at the enzyme deficiency using the genotyping. By Rida, he looked at 851 patients, and he only genotyped them for the 2A variants. And he found those patients to be, the incidence was found to be almost 1%. And I'll summarize those in one of the subsequent slides. And then there is another study that was done in Egypt. Egypt is a very interesting country because it's between Africa, Asia, and Europe. And they looked at multiple genotypes incidence, and they found different incidences in that study. So this is kind of like a map of the world. So if you look in America, the incidence seems to be 3 to 5%. In Japan, probably 0.7%. We know that there is at least 1 Indian patient that had this enzyme deficiency. There are multiple other reports of Chinese and some other ethnic groups that also were found to have DPD deficiency. Now, the racial differences, like I said before, African American tend to have higher incidence of DPD deficiency in one study. Also, between males and females, females tend to, or at least have shown to have higher incidence of this enzyme deficiency. Now, how do you inherit this gene? It seems to be a codominant pattern. So if you have the mutation and you inherit this mutation, you are going to be deficient of the enzyme. The deficiency can be partial if it's a heterozygous. If you inherit a mutation in the same chromosome from both sides, you're going to be a homozygous. If you inherit multiple mutations in from one side or from different side, you can be double heterozygous or multiple heterozygous. And this gene, it's present on chromosome 1p22. So this is, in my opinion, a very important slide because that's going to explain some of the conclusions that we're going to try to make at the end. The gene is pretty complex. You have multiple variants within the gene. And that's why if you look at only one specific variant, you're only testing that specific variant. You do not have an idea of the entire gene. The DPD2A, which is, this one is not working, but if you look at the DPYD2A gene, this seems to be the most common studied and found variant. It's an exon 14, and this seems to have been associated with decreased DPD activity. Multiple other variants have been looked at. Some of them were thought to be associated with a normal DPD activity. Some of them are associated with decreased DPD activity. Some of them we still don't understand this very well. So there are multiple variants that when we do testing, we need to be careful about how we interpret those results. Now, among those variants, we have two published studies that looked at patients with toxicity and families who had DPD deficiency. And when we sequenced multiple variants, it's pretty clear that the DPYD2A has been the one that was identified the most. So in the first one, 43% of the tested mutations were DPYD2A, and then subsequent to that, we found 9A in one variant, 9A in a different variant, and then 13, 9B, and 6. And then another study that 2A was found to be present in 52% of the population. So that just give us an idea how testing for multiple variants is important, not just to limit our testing to the 2A variant. What's the impact? For us who practice oncology and give the drug, most patients who you give them 5-FU would have maybe a grade 1 to 2 toxicity, but some of them can have severe toxicity. The toxicity of 5-FU can be diarrhea, mucositis, myelosuppression, skin toxicity, hand-foot syndrome, neurotoxicity, and hair loss. There is a reported case of a life-threatening toxicity from even a topical 5-FU that was given to a patient who had a heterozygous DPD deficiency. And obviously death. Death has been reported in both heterozygous and homozygous. Patient with complete deficiency, the incidence of death is pretty high. It can reach up to 100%. So given the importance of this, we have two published articles that were published recently. This is one of them that showed that if you decide to upfront genotype your patients for the DPYD2A variant, which is not complete, but at least it's some of the work that you need to do. It's been proven to be safe and cost effective on a population level. So that's good. And there's another study that basically shows us and proved to us the point that you shouldn't limit your testing to the 2A variant, even though it's the most common, but you should include other variants. And in that study, they included some of the other variants. Here was 9 and 13. They just gave the generic mutation here. How would this impact the treatment, us as an oncologist? If you have someone with DPD deficiency, how this would impact you? We should avoid using 5-FU in patients who are homozygous for DPYD. The reason why, because the incidence of death seems to be pretty high. Now, if you have a patient that's heterozygous, a reasonable approach would be to give 50% of the dose and then to titrate according to how much toxicity they experience or they develop. And the third point is there's a new drug that was approved last year, Lonsurf, that seems to be safe in patients with DPD deficiency. So you shouldn't worry about using this drug in patients in this population. And if you have toxicity from 5-FU, if you have someone with DPD deficiency, or if you have a patient that has overdose from 5-FU, what you need to do, you should discontinue the drug, and then you could possibly, down the road, dose reduce. You should provide aggressive supportive care. You should give growth factor support. And there is 5-FU antidote, uridine triacetate. Dr. Cameron and I, one time we had a patient that instead of getting the 5-FU over 46 hours, he was given the drug in 4 hours. So we use this antidote, which has some theoretical help. Now, if someone has good kidney disease, you don't need to do dialysis. But if someone has problem with kidney disease, you might use hemodialysis or hemoperfusion. So where is this taking us? I think it's nice here to kind of share experience that we have in MCI. And I think we have contributed to science, and I think we should, or we hopefully were able to contribute more. And I really should give credit to Dr. Taylor, because when I joined MCI, he has, by that time, diagnosed 14 patients with DPD deficiency. And this was the initial work that we have done. And also, I want to give credit to Cindy. She's here, because she's the one who really identified most of those patients in our EMR. I looked for a picture for you on Google. I couldn't find any picture, otherwise I would have. So what we did, we basically looked at our database from 2011 to 2016. At that time, we identified 35 patients. I think now we have almost 70 patients that were tested for DPYD gene mutation. So what we for those patients, they were tested by either ARUP or LabCorp. All patients were tested for the 2A variants. That's just because this is the standard one that get tested. LabCorp only tests for 2A variants. Some of the other patients have been tested for other variants, mainly 9A, 13, 9B, and this fifth variant. We did grade the toxicity according to the National Cancer Institute Common Terminology Criteria for Adverse Events, and we performed our statistical analysis using Fisher exact test. So the median age for our patient was 60, ranges from 32 to 80. We had more females in our cohort compared to males. Most of our patients were Caucasian. 20% of our patients were African Americans. We didn't have any other ethnicities apart from Caucasian or African Americans in our cohort. The most primary diagnosis was colon cancer, followed by rectal, anal, pancreatic, and then gastric and esophageal. The chemotherapy regimen was either capecitabine-based or 5-FU-based. And in our cohort, we found 40% of the ones that were tested had DPYD mutation, while 60% had a wild type according to those tested variants. Obviously, this number could change if we tested more variants. So this is a nice, I think, diagram to explain this. So for those 35 patients that we have looked at, 21 patients had no identified mutation within those tested variants. But 12 patients, 34%, had the 9A mutation, which obviously is something that isn't consistent with what we have known from the literature review, because 2A seems to be the most common. However, in our cohort, we identified more patients with 9A mutation. And only 2 patients among all those patients had the 2A mutation. So this slide basically summarizes the importance of testing other mutations, because if you only limit your testing to 2A variants, the one to the right, the diagram on the right, if we have only tested our cohort for 2A variants, we would have only been able to identify 2 patients, which is 6%. But when we expanded the testing and we included other variants, if you've noticed, but that's only for 24 patients of the 35 patients, 54 of them were identified to have a mutation. Obviously, those patients are selected because they either have toxicities, or some of them were old or had comorbid diseases that Dr. Taylor thought it would be ideal to test them before they get exposed to the drug. So that's just an example of how, and that supports the other paper that was published before that I showed you, that it's ideal to test as many variants as possible, because that increases the chance of you identify those patients. The adverse events that our patients have experienced, I highlighted diarrhea because that just struck me when I reviewed the charts, that most of the patients that had toxicity had diarrhea. And grade 3 diarrhea was almost present in 54% of the patients that we have reviewed. The rest of the side effects, all of them were almost single digits in terms of percentage. So diarrhea somehow came just so striking when we looked at the toxicity. And when we tried to break down the diarrhea side effects, for patients who were DPYD mutant, 64% of them had diarrhea, grade 3 diarrhea, while the one who had wild type, it was 48%. But see, like I said, some of those patients had comorbid diseases or old age, so when Dr. Taylor tested them and he found that they were DPYD mutant, he gave them 50% of the dose. So if you look at patients who received 100% dose with no dose reduction, 100% of the patient with DPYD mutant variant developed diarrhea, while it was only 53% in those that were wild type. And obviously those wild type, we think they are wild type, but they could have one other variants that we just haven't been successfully identified. So that's, in my opinion, that's a pretty interesting information. So now, since then, I've been pretty cautious. If any of my patients that I give 5-FU develop diarrhea, especially if it's grade 3, to me, that's an automatic testing for DPYD. When we did the statistical analysis, obviously this was a pretty, that was statistically significant, and the p-value was less than 0.05. So the conclusion that we have drawn from our experience, the following. In patients treated with fluoropyrimidines, the rate of grade 3 diarrhea was significantly higher in patients with mutant DPYD gene. I showed this to you. Testing for DPYD2A alone to diagnose DPYD deficiency is suboptimal. I think there's no question about that. Testing for other DPYD mutation variants, including DPYD9A, which is the one that we identified the most, represent a more comprehensive approach. What's my message to oncologists? I believe that every oncologist should consider upfront germline DNA genotyping, especially if your patient is an old or has multiple comorbid disease. The reason why, because if your patient is sick or old or has multiple comorbid diseases and you give them a full dose and they have the enzyme deficiency, that might just make things more complicated. It's cost effective. Testing for this, in my opinion, would be ideal. If it happened and you didn't test or you don't want to test, that's perfectly fine. But if you need to have a very low threshold for testing your patients if they develop grade 3 toxicity, especially diarrhea. Now, we should all recognize that a negative DPYD germline DNA genotyping should be interpreted with caution, as it only reflects the status of the tested variant. So I'm sure that there are so many patients that were tested for this and they were told it's negative, but it's true they're negative for that specific variant, but it doesn't mean that they do not have the gene deficiency. And one other information, we all use sometimes a combination. 5-FU, typically we don't use it as a single agent. Obviously sometimes we do, but there are multiple occasions where we would use it in combination with other drugs. So if you use 5-FU with irinotecan and FOLFIRI, your patients could develop toxicity, but you need to be aware also that irinotecan itself could be the reason why they develop that toxicity. And there is an FDA-approved test to assay for the pharmacogenomics syndrome of irinotecan toxicity, which is the UGT1A1. If you guys are familiar with liposomal irinotecan, when they did the study, every patient that received liposomal irinotecan was tested for UGT1A1. So in summary, I believe the incidence of DPD deficiency is estimated to be around 3 to 5%. That's based on the enzyme activity from peripheral blood mononuclear cells. The 2A variant, which is the answer for the question, if you have done the questions, is the most studied and seems to be the most common variant detected. Upfront testing is safe and cost effective. If you only test for 2A variant, it's suboptimal. And if you're a clinician and you have a patient that you suspect heterozygous mutation, starting a 50% dose and then titrate according to how much they tolerate the treatment is a reasonable way to treat. Thank you.